sister.
Hi, I'm Christine von Reisfeld. You know me from our past Lupus 101 series. I'm here with Tanya Mackey today. She's the transplant coordinator at Stanford here. And we have a couple of questions that you've pre-submitted. We're going to go through those questions, and we're also going to take some live questions from you as the broadcast goes on. So feel free to ask any questions that you have. We'll get to them in the order that you put them up on our screens. So I'm going to let Tanya do a little introduction about herself, and we're going to go start right into our questions. All right?
Hi there. My name is Tanya, and thank you very much for inviting me to be here today and talk a little bit about living kidney donation, and I'm going to touch about kidney transplant a little bit. I've been a transplant coordinator here with Stanford for about the last 16 years, and I've been working specifically with living donors for about on and off the last 4 to 5 years. So I'm going to just go ahead and start with the questions that were given. I'd love to have more questions as I talk, so please feel free to chime in here and there. So one of the first questions that I received was, at what stage of nephritis is a kidney transplant necessary? So this pertains more to the recipient side of transplant. So something everyone should know is that you are eligible to get your name on a kidney transplant list when your GFR, or an estimated GFR, which stands for a glomerular filtration rate. If I use some words that people don't know, please feel free to ask me as well.
Okay, great.
So when your GFR is 20 or less, so that should be way before anyone's on dialysis. So it's always good to know, what your kidney function is. At that time, you can contact a local transplant center to be evaluated, okay? And you can either, if you're already on dialysis, you are eligible for transplant already. Usually, if you are looking for what we call a preemptive kidney transplant, that means a transplant before dialysis is needed. It is when a GFR is between 10 and 12, roughly. Everyone's body is different, so it depends how they feel. Some people might feel great with a GFR of 10 or 8, and some people might feel terrible with the GFR of 12. So always listen to your body and talk to your local nephrologist about when's the appropriate timing to be referred and evaluated for transplant. So once the recipient is determined to be a kidney transplant candidate is when we tell our patients here at Stanford that, hey, living donation is a great option. And the reason for that is, unfortunately, the waiting time here in the Bay Area is very, very long for a deceased donor kidney transplant. The waiting time, depending on blood type and an antibody level, can be anywhere between 6 to 12 years. Okay, so that's a really long time when you're waiting for something you really want, right? Waiting is the hardest thing in life. So we want to explore the possibilities of living donation with our potential recipients. Living donation is a great option because a living donor kidney actually does last longer than a deceased donor kidney. Living donor kidneys will last on average about 18 years, whereas a deceased donor kidney on average lasts about 12 years. And the reason why is it's a much more controlled environment with living donation. We usually have both the donor and the recipient here at the hospital at the same time. There's no shipping of kidneys on ice. And that's what can impact, how quickly the kidney starts working and how long that kidney lasts. So I'm going to go ahead.
I have a quick question
yes,
for you.
Great.
So if you have a kidney transplant, are you guaranteed to have another transplant in the future? Do you have to have one, or can you go the rest of your life on one?
So it depends on the age of the recipient, right? So we have had people who have had their kidneys for 20, 30 years and are continuing to go on. Usually it is the younger people who get transplants in their early 20s who may end up needing a second transplant. We do have older people who also end up needing a second transplant. So we emphasize here at Stanford that transplant is not a cure of your kidney disease. Okay, so the kidney transplant can fail, and you basically are faced with the same situation where do you get a transplant or do you stay on dialysis? Okay, so we have people who sometimes need a third kidney. So it's a roller coaster that everyone has to kind of be prepared for, but there's options. The good thing about kidney disease and kidney failure is you have options, and the options are dialysis, and within dialysis you have hemodialysis and peritoneal dialysis, or transplant. And all of those are treatment options and not cures. And so we always remind people that as they're considering transplant.
So why does a donated kidney last less than a lifetime? Like, why is there a reason that it won't last a lifetime?
So when you're giving someone a kidney, they're only getting one, right? And so it's kind of like 50% of a full package, right? So when someone has 2 kidneys, they're gonna, they should be fine. As you get into your 60s, for everyone who has, great kidney function, you still see a gradual decline of kidney function with age. So it really depends on, how well that kidney's been working, the course of it. Have they had bouts with rejection, which I'm going to talk about rejection in a while, and how well has that transplant worked for that recipient over the years. So not everyone will need that second transplant, but some people might.
Some people.
Definitely. Okay, so one of the questions was, how can I be a living donor? And so what you want to do is, once the recipient or that you want to donate to, or if you want to be a kidney donor, you contact the transplant center that recipient is listed at. Most transplant centers have a web-based application now that you can apply to be a living donor on. Here at Stanford, our website is stanfordhealthcarelivedonors.org, so people can go onto that and they fill out kind of all the questions. It is, lots of questions about that person's health. Are they taking medications? Have they had surgeries in the past? Their habits, such as smoking and drinking. And so it takes them through a number of questions, and we then get that questionnaire here at Stanford. And we review it, and then we contact that person, and we'll start to go through the process with them. If for some reason someone doesn't have access to the internet, which some people don't still, they are also more than welcome to call in, especially if they don't speak English as a first language. We can get interpreters on the phone, and that phone number is available too.
I'll post all of those on the page afterwards too, so if anybody wants to refer to your link, we'll have it there.
Perfect. And I think the key is remembering that you want to go to the transplant center that the person you want to donate to is listed at. That's important. We tell everyone that living donation should not be taken lightly. It is not a quick and easy surgery such as getting your gallbladder or your appendix out. It is considered major abdominal surgery that can have its own risks, later on in life. And so we like to provide people with a lot of information about kidney donation. It's our job to do that. We're not trying to scare people away, but we really want people to research and decide, if this is the best option, best decision for them or not. So there are a lot of tests to go through if you want to be a donor, and that was one of the questions too. So once the screening has been reviewed, there's kind of 3 rule-outs that we have here at Stanford for being a living donor. If you have diabetes, you cannot donate. And the reason why is diabetes can impact kidney function, as most people know as well, and that person may end up needing a kidney transplant in the future. If you've had a recent history of a kidney stone, that means probably within the last 10 years, that needs to be taken into consideration as well. If you have a history of cancer, more likely you will not be able to donate. And hypertension, a history of hypertension for donors needs to be taken under consideration. So it's not an automatic rule out, but we will look into that a little bit further. If you do have a history of diabetes, we do make our donors go through something called the glucose tolerance test, which many people might be familiar with. It's something that women do when they're pregnant as well. And so if they show that they have impaired glucose or glucose intolerance, then we will rule them out as a potential donor, because it shows that they have increased risk for diabetes later on in life. Many transplant centers also have a BMI requirement, which stands for Body Mass Index, as most people know. And so our BMI requirement here at Stanford is around 30. Each transplant center, by the way, has a different set of policies. So I'm only speaking here at Stanford, so you can always contact those other transplant centers to see what's going on over there. So here at Stanford, once they've come forward, we do kidney function tests to look at how the donor's kidney function is. In order to be a donor, they have to have a GFR of 80 or higher here at Stanford in order to give away one of those kidneys. That lets us know that that person hopefully will not end up with kidney problems themselves down the road later on in life. So if they come in with a GFR of like 68 or something like that, then we're probably not going to let them donate, because it's not going to be good for them in the long run.
Oh, wow.
Or 70, even in 70, 75. Okay, and so we also do kidney ultrasounds to make sure that people have 2 kidneys in there. We've actually discovered sometimes that people only have 1 kidney and didn't know about it.
Really?
Yeah. So it's,
wow.
sometimes we pick up stones in both kidneys, and if you have bilateral stones, that means kidney stones in both kidneys, we also will not let you donate. And then we do go on to compatibility testing after that, which is actually just a blood test, but it is made up of different components. And so one of the other questions was, let's see, what makes a kidney a match? There's a few different things we look at. One is blood type. So is the blood type compatible between the donor and the recipient? The second test is called a cross match, and that's where in the lab they actually mix the white blood cells of the donor and the white blood cells of the recipient in little test tubes. And if they see that there's a reaction between the recipient's blood cells and the donor's blood cells, that means that that recipient will reject that kidney right away. So it's the immune system showing us the response in the lab, and so that we will then say that that donor is not compatible with that recipient. The good news is most transplant centers can participate in exchange programs now. So these are not barriers to donation. Pairs can decide to participate in the exchange program. We participate in the NKR, which stands for the National Kidney Registry. So that if you still come with your living donor, they can end up donating to someone else in the registry, and the recipient can receive a kidney from someone else in the registry. So it's a pretty amazing process that's been in the works for about the last 10 years at least or so. So it's a great process. Living kidney donors are very scarce, and we want to encourage as many people to come forward, but it just needs to be a well thought out process for those people. So we have blood types, we have cross match. One of the last things we look at is tissue type, which is also known as HLA. You do not really have to have any markers in common, but the best possible match that anyone can get a kidney from is someone who is a perfect match. The most likely person that is a sibling who has the same mother and the same father. There's a 25% chance that that sibling could be a perfect match with you, and that is the best kidney that you can get. We actually do here at Stanford have a research protocol going on called the Tolerance Protocol, and that is for people who are a half match. So that can be parents wanting to donate to their children, or children wanting to donate to their parents, or siblings who have that half match. And the goal of that study is to try and get the recipients off of immunosuppression, which is medicine that basically the recipient has to take for the lifetime of the kidney transplant. And unfortunately, those medicines do have their own side effects, which I'll kind of talk about later on. But it's been really successful so far, and it's become kind of known around the nation, the tolerance protocol. Okay. So I think one of the next questions is, I'm going to talk about surgery for the donor. Okay, so once the living donor has actually gone through the full medical evaluation and psychosocial evaluation at the transplant center, and they're deemed as, cleared from both of those perspectives, we end up setting up surgery. We tell our donors that it's the most thorough physical that they will ever get in their entire life, and we ask them very personal questions, and so we don't want anyone to be offended about the questions that we ask, but it is important to get a clear picture of the donor and trying to decide if this is the right thing for them to go forward and do or not. So most of the donor surgeries are done laparoscopically now. Okay, so in the olden days, in order to donate a kidney, they would do like a big cut on your side, right, because both your kidneys are in your back, basically. And so what they can do now is called laparoscopic surgery, which is 3 very small puncture hole wounds where they put in a camera. They blow your belly up with air, and they have a tool that helps them isolate the kidney. And the kidney comes out of about a 2-inch incision that is under the belly button. Okay, and so there's no longer a big cut, but it still is considered major abdominal surgery. So I'm going to use this little thing here. So one of the last studies our donors go through is an MRI. For some reason they can't have an MRI. They can do a CT scan. This is an MRI result of one of our donors, and as you can see, this is the aorta that comes down here, and what it's doing is it's showing all the blood vessels that go to the kidneys, and this person actually has 2 vessels going to each kidney. Ideally, if you're a donor, you only have one vessel that perfuses the whole kidney, because what needs to happen with this person is that the surgeon will actually have to clip both of these vessels, because when the kidney is taken for donation, you take the blood vessels that go to and from the kidney, as well as the ureter that comes from the kidney. The ureter is the little tube that runs from the kidney to the bladder. So all of that's taken from the donor as like a little plumbing package, and it is given to the recipient for transplant. So it all needs to be looked at very carefully. The anatomy is very important. Let's see. So let's talk a little bit about the surgery. So the laparoscopic surgery is a longer surgery than an open surgery. It usually can take anywhere from 3 to 4 hours long, it is a 6 to 8 week recovery period. And so many people think they're going to kind of come in, donate their kidney, and be back to life in about 3 to 4 weeks, and we really try and press upon our donors that might not be reality. Your body is putting a lot of energy into recovering from surgery, so you tend to fatigue very easily within the first 6 to 8 weeks. You feel kind of bloated sometimes afterwards because of the laparoscopic surgery, and they blow your belly up with air. Sometimes people have nausea afterwards just from the anesthetic, because that stays in their system for about 72 hours. And I think people are actually surprised that the recovery period is as long as it really is, because I think, luckily most donors are healthy people, so they're not used to being in the hospital, and they're used to kind of living life. And when we tell them that, okay, you might need to, scale back and you won't be able to work, for anywhere from 4 weeks to 8 weeks. It's hard for them because they're people that usually go stir crazy when you tell them they can't do anything. So we always try and mentally prepare them for that. One of the biggest restrictions post-surgery is no heavy lifting, and that's anything from more than about 10 to 15 pounds for about 6 weeks after surgery, and that's just because it takes about that long for all the abdominal tissues to recover. So once you give that kidney away, so we remind our donors that giving one kidney away decreases kidney function on average from about 25 to 35% for the rest of their life. And so we encourage all of our donors to live a very healthy lifestyle, and that just helps them from going on and hoping not to develop hypertension as they get older, diabetes as they get older. Really, the younger a donor is, the harder it is to predict what their lifetime risk of donation is, just because they have so much life in front of them. We really cringe when we see people who come forward who are like younger than 25 years old, just because they have so much life to live, and we don't know what their health's going to be like in their 60s. So we take extra time talking to our younger donors. Long-term, so one of the other questions we received are, what are the long-term risks of kidney donation or transplant? So I'm going to talk about that a little bit.
Can I ask you one quick question really quick? While we're talking about the donors, what's a healthy lifestyle for a donor, like related to like food and alcohol? Are they?
Yeah, good question. That's actually a great question. So there's no, everything in moderation, right, for all of us. There's no contraindication that they cannot drink alcohol. It is okay to drink alcohol post-donation in moderation, of course. We here at Stanford prefer our donors don't smoke. And it's just because that can lead to vascular disease down the road, and you need those blood vessels to be as healthy as possible for your own kidney. And I think kind of just keeping your BMI, which is your body mass index, as we get older, our metabolism tends to change, and so every decade you notice that's much easier to gain weight, and the higher someone's BMI is, basically the higher at risk they are for high blood pressure and diabetes, which are two medical issues that can really impact kidney function. Living donors have also been noted to be a little more at risk to spill protein in their urine, which could be a possible very early sign of kidney problems. So we always monitor that for at least 2 years post-donation, and then we encourage people to get after 2 years. We don't have to have them come back to the transplant center, but we really encourage our donors to get an annual physical with their local doctor. The other thing is we ask people to stay away from NSAIDs post-donation, which are non-steroidal anti-inflammatories, such as aspirin, Aleve, ibuprofen's a huge one. So, that's what's in Advil and in Motrin. And the reason why is all of those medications are metabolized through your kidneys. And, a lot of us could just pop Advil here and there without really thinking about it. But long-term chronic use of that is actually very hard on kidneys and very bad for kidneys.
So you recommend staying off of NSAIDs for the rest of their lives?
Or use very, very sparingly. Someone has a pain issue. Pre-donation, we actually talk to them about that, and it may be a contraindication. Chronic pain may be a contraindication to donation, just depending on how well it's controlled. Post-donation, if it's like an orthopedic injury or something like that, there's a lot of other pain meds that are out there that we prefer people to use instead of using the non-steroidal category, just because kidney function. Okay. Okay. Next question. Okay. So I think recovering, so I'm going to talk about the transplant side of it now. Is because one of the questions also was a long-term risk of transplant. So anyone receiving a transplant always needs to remember that hand in hand with transplant comes the possibilities of rejection, of that kidney transplant failing, and the other hand is infection. So people who have a transplant, most of them take immunosuppression medications, and that's because we don't want that immune system to recognize that that kidney is not their own kidney, because if it recognizes that kidney is not their own kidney, it's going to try and attack it and reject it, and because that immune system is very, very smart. So that's where immunosuppression medications come into play. Our patients are usually on a combination of possibly 2 to 3 immunosuppressive medications. For as long as that kidney works, they have to take those medicines in order for that transplant to be a success. Even with the medicines, sometimes that immune system is smart enough to figure out that that kidney is not theirs and and will attack it, and that is a episode of rejection, is what we call. The good news is that rejection can be treated if it's caught early enough. There are some other medications out there, the stronger medications that we use to treat rejection, and hopefully it will stop the rejection from attacking the kidney completely and it failing, and that kidney will go on to function for many more years. The more episodes of rejection, the chances that that kidney is not going to last as long as it should. It just decreases the life of that.
So we do have another question. Would lupus patient recipients need to up their immunosuppressant?
So it's actually, transplant kind of plays a dual role in lupus patients, which that's a great question. So in order for a lupus patient to receive a transplant, their lupus basically needs to be in remission, or they need to be on a very low dose of immunosuppressants. So we do try and wean people's prednisone down as low as possible if they're on prednisone or Cellcept. I'm not sure what other meds they're taking a lot. And what actually happens post-transplant is the immunosuppressants that are being given for transplant help with the lupus as well. So you're kind of being covered on both dually, on both sides. So it's actually a good thing. One of the other questions that we were discussing before this was someone had asked if lupus comes back in the transplanted kidney or there reoccurrence of it. I can just say here at Stanford is very low incidence of recurrence of lupus. Usually that kidney would fail in that patient for some other reason other than lupus, but every case is different. And if that were to happen, what happens is those transplanted kidneys are usually biopsied so they can tell, is the kidney really being affected by the lupus again, or is it immunosuppression toxicity, which is another concern with transplant. So we monitor those medication levels in the body with blood draws, and our team is really great at trying to figure out what's the best path of treatment so that transplanted kidney can last for as long as possible. Did I answer that question?
Yeah,
okay.
We're good.
Okay. So the other side of taking those immunosuppression medications is that it does suppress your immune system, which can, as most lupus patients know, make you more susceptible to bacteria or prone to infection. And so we're always keeping an eye on that, telling people the best thing you can possibly do is wash your hands post-transplant, before you eat, and just have good habits. If you know someone's sick or has the flu or something, try not to visit with them or don't share a bed with them that night, kind of protect yourself so you're not as exposed to as many colds and flus as much as possible. So, what else? I'm kind of trying to decide if I've answered everyone's question or not. I'll try to think of. Let's see.
We're looking at the questions right
Okay,
now, too,
okay, great.
Also, so I was thinking a little bit about when you were talking about, Stanford prefers that, your BMI be in a certain range or whatever. So first, is there also a lower limit to the BMI that you require? And also, if you could talk about a little more specific about what the weight-related issues are for live kidney transplant.
Yeah, good question. So we don't have a low end of BMI actual issue, but if someone sometimes people's albumin level is low, which means that they are kind of their health is not as good as it should be, and that will show us, the albumin level will usually show us, we will have, we'll basically say you need to kind of get yourself a little healthier. It's not, having a very, very low BMI is also not healthy for most people. On the up end of BMI, the reason why we don't let people donate who really have like a BMI of 35 or something is, it is abdominal surgery, so they have to go in through, all the abdominal tissue. It can definitely increase the risks with the actual surgery itself. So bleeding, at time of surgery increases wound infection, because the more tissue you have in your belly, the harder it is for all of that to heal up. Is also something to be considered, and possible development of a hernia post donation is a consideration too, and that's why we're really warn people about lifting heavy stuff. So the better ab muscles you have in there, usually the better the recovery is. But for living donation, our center really considers it as an elective surgery, right? These wonderful people don't have to donate a kidney. They are getting no medical benefit to themselves by doing this. And so we are very protective of our donors and always want to keep their best interest in mind. However, when it's a family member that's getting that kidney, especially, a family member living in the same house with them, that family really benefits from that transplant. Everyone benefits from having someone healthy, in their family, and that's why transplant's such a wonderful thing. A lot of spousal transplants, are amazing because the relationship really just, blossoms afterwards. The donor, one thing I didn't really talk about. Does that answer the question? Okay. One thing I didn't really talk much about is the testing that the donors have to go through, because once we know whether they're compatible or not, a lot of people think they're just going to walk in and walk out and know whether they're going to be able to donate the kidney, but they really go through a whole gamut of blood tests. So we're looking at their kidney function, we're looking at their liver function, all their blood counts, and a lot of viruses, so hepatitis B, hepatitis C, and they're getting a EKG and a chest x-ray. If they are over the age of 50, we do have them do a cardiac stress test as well. For our non-blood relatives, who are someone who is not a first-degree blood relative at Stanford, they have to go through a psychiatric evaluation here at Stanford, and then they go on to the imaging, which is like an MRI or a CAT scan, which we talked about. So it's a definite process to be evaluated as a living donor. A lot of people, and it's time off work to come in and do those tests, or time away from home, and if you have kids at home, you need childcare for those people. So we understand that, it's asking someone a lot to go through that process. But it's our job to educate our donors, and so we give them a lot of food for thought, because ultimately, if we don't find any medical reason that they shouldn't donate, it's up to them to decide if this is the right thing for them to do or not. And some people, after they come in and they receive all the information and find out what the risks are, might not be comfortable with moving forward.
You had mentioned earlier, you had touched on toxicity.
Oh, yeah.
Can you explain a little bit more about
Great question. Great question. So the medications that we use for to help prevent rejection, the two big, usually it's Prograf now. The older one is cyclosporin that we still use sometimes. So they're great meds to help prevent rejection. They're also used in other transplants like liver transplant, heart transplant. The problem is it's a delicate dance because you want them to have enough medicine so they're not in rejection, but then too much medicine is actually toxic or bad for the kidney. And so this is why blood draws are really important for these people, because we're checking the level of that medicine in their system, and we will adjust that dose based on the levels that come back. And it's important to keep the level controlled, because if it gets too high and it's too long over a long period of time, it will be toxic to the kidney and will cause the kidney to stop working after a period of time. So that's called the toxicity.
Okay.
Immunosuppression.
Thank you.
You're welcome.
So I have another question, which is, let's assume that two people are compatible. So what would you say is the average length of time from the time they walk into your clinic to the day of surgery?
So we tell our donors, great question. We tell our donors on average that the workup time is 3 to 6 months. We have done them in as little as 2 months or 6 weeks. But a lot of times we uncover issues in the donor that they didn't know were there. And that requires a little more testing or looking into, and that can make the evaluation last longer. I mean, I've had some donors undergoing evaluation for a year or longer. Yeah, so there's no perfect answer because it really is dependent on what are the findings of their tests. Are they all normal? Then we can proceed to step number 2, or if they're abnormal, then it requires more investigation before we can go on to the next step.
And you talked about siblings being having a better chance of being a fit. So then, following that logic, can you address the subject of twins, either fraternal or identical?
Oh yeah, great. So identical twins, will have a perfect match, basically. They should. And so that's possibly the best kidney that person could ever get. However, the donor of that identical twin has to want to donate. so that always needs to be taken into consideration. I'm not a specialist on twins. I believe fraternal twins, as long as the blood types are compatible and the cross match, which is that other test I talked about, is negative, which means compatible. They still may be like a 0 marker match, which most kidney transplants that are done are actually that 0 marker match. But those are still great living donor kidneys that have a chance of being much more successful than and decrease the time that people have to be sitting around waiting for a deceased donor kidney. So it doesn't have to be a blood relative. It doesn't have to be a sibling or a parent, spouses, good friends, cousins, all those people. We always tell people, and if you have anyone who's interested in donating to you, have them come forward. We'll talk them through the process and find out, again, if they're not compatible directly, they also have that option of the kidney exchange program.
What about support for people after their kidney? Are there support groups? Do you recommend psychological counseling after?
Yeah, so we're lucky enough to have a great team of social workers here at Stanford that will that are available to all our donors and recipients even after, as long as the kidney transplant's working, or if there are any issues that the donor had afterwards. Our social workers would be available to them. We also have connections with the psychiatry department if needed. I think people underestimate how, how much anxiety there can be, with the whole process and post-surgery. And, all donors should be a little bit nervous because they're going to undergo major surgery. And when they're not a little bit nervous, we start to get nervous. And if for some reason, they're not local, our social workers would help them reach out to community mental health if needed. There is an assistance, a National Living Donor Assistance Fund, also that possible living donors have to actually qualify financially for it, but they can also help with travel to and from transplant centers, hotel stays if they need to stay locally. Not everyone qualifies, but it's a great resource for the living donor population. Yeah.
So I think that's all we have. So I'm going to step back in with
Great.
you for a second. And I want to thank you all for submitting your questions beforehand. I forgot to mention in the beginning that we're the Lupus Foundation of Northern California, and we do have our Lupus 101 series once a month. So next month, I'm not quite sure what we're doing, but we are going to have one next month. We'll keep you posted on that. And I'm going to post Tanya's information on our website so that if you have any questions, you can contact her or you can contact Stanford here. And I think that that's all we have.
Thanks for having me.
Thank you so much. It was a pleasure. Thanks.